we are all a little behind, so I try to do a little quick. And first of all, like everyone, really thanks the invitation and hospitality from the conference, university, Professor Todd, and just some of the information is from one of the symposiums we ran a few years ago. And there are also going to be published supplement very soon, I think later, maybe October, with the American Journal of Preventive Medicine, really talk about setting cutoff scores. That's mainly on the fitness graph. And then I also have a few slides from the colleagues. So let's start a problem. And there's a statement a few years ago from the U.S. The journal, the U.S. News World Report said 17% above the 90 percentile. Really talk about the childhood obesity. Okay, so what's wrong? Well, here is the 95 percentile. Here is 17, right? So we all learn in the go back a little bit background. For the CDC, when they define the obesity, will be any children at a certain age, if BMI is larger than the 95 percentile, was considered about obese. And so a percentile really is supposed to reflect a value at below there are certain percentage fail. So above the 90 percentile really means they're supposed to only 5%. Okay. So what's wrong? But let's look at the little bit of background and how we get there. Youth fitness is every country's interest, and for a long time, in fact, that often triggered by the war. Now, in the U.S., the youth fitness really started from a very small study and close related to Europe, in fact, and it published in 1953 and 54, but mainly 54 bring a lot of attention by the researchers. If you look at the tests today, you will say, well, this test is not really valid in terms of measure the physical fitness. It's more like a motor function, and basically whether the kids can stand up just one times, and whether they can lift their legs up, whether they can touch ground, and so on. Okay. But the main thing bring the attention is compare the children, U.S. and the European countries, several. And I think maybe we have several people from these countries. And the U.S. children has much higher fail rate. I think if you do the same test fail, you get similar results too. And across all the different age. Now, that time, the Korean War just finished, and it's in the middle of the Cold War. So the President Eisenhower learned the news interestingly, from the first author, who is also the personal doctor of the president. And it's interesting also, kind of also talk to students that quite often, many youth fitness study early days was done by the physicians. So he learned the news and he's worried and don't have enough young men ready fit to the war. So he really pushed it and established the President Council on Youth Fitness in 1956. So in the U.S., the first national study done was 1958. You can see that time there are a number of we call performance-related fitness. So 50-yard dash, shuttle run, and so on. And so that time, the interest for the evaluation is normal reference. Really try to compare our children with the average and with others. The hope that time is the stronger, faster is better. Now, so they also established some of the wall, and for example, would be the golden wall, would be the 80 percentile, and so really encourage the kids who do well in the fitness performance. That wall is still here, and later on is changed to as the present challenge wall. Now, that wall basically said is there's a 5 tests, you have to get 5, all the 5 tests, 85 percentile to be able to get the president certification. And so if you look at the tests, today I sometimes challenge my students and the college to say, well, if you see that said, let's pick up the 1 mile run. So 10 years, 12 years old boy, you need to finish the running 7 minutes, 11 seconds. A lot of our college students cannot do right now today. So it's very hard. So, but when you use the normal reference to do the evaluation or setting standards, and there's advantages, disadvantages. Advantage is it's very easily developed. If you get a large representative sample and run the mean standard deviation, calculate the percentile, you get the standards. Well, there are several limitations there. The first one is very difficult to update. U.S. hasn't done any national study for 20 years, more than 20 years. And the major problem is when you use the normal reference, do the evaluation, the population, majority population have to be healthy. In that case, the average, about the average has meaning. Otherwise, if everyone is not fit, about the average means nothing. Okay, so that's really the major problem. And also, there are people also thinking that, when we have the kids, and most time is the less fit kids have a great potential when they grow up will become sedentary adults or unfit adults. But when you have very high standards and do the test, they say, well, I never really reached that 85 percentile. So they are discouraged by the physical education, by the physical fitness test. That's really the problem. And then we all know that, especially in the U.S., and in the 80s, and childhood obesity become a major problem. But it's not just the U.S. right now. This is the kids in China and Germany and the United States. So the childhood obesity is everywhere around the world. And now, the standard we talked about at the very beginning, that problem statement is really come from the world in the 1960s, 70s. The CDC standard is really developed based on the 60s, 70s standard. So that time, 85 percentile is, considered about below, or 85 or 95 was considered about healthy if you below that percentile. And we have several arguments with the CDC people say, at least you should say this is 85 percentile based on the 70 years data. And I think that if you pay attention, sometimes they have a small print, the fine print under that. But most of the people have a little misunderstanding about that part. But the percentile, I think all the people take the first measurement class will automatically thinking if you talk a percentile, that is associated percentage. And so 85 percentile means that 80%, 85% of the population should be below that number, which is not true. So go back to the beginning statement, and that's the problem is when the population get to the gain the weight, and then it's no longer the 5%. In the 2007 is 17%. So that's we see the earlier problem. So the interest really changed right now from the performance-related fitness to the health-related fitness right now. To be able to do the health-related fitness, you have to use different way to do the evaluation. And there's a number of articles talk about health-related fitness and why it's important, the validity, and so on. That has been well documented. And in the United States, there are two really tests. The earlier has been the physical best, which is gone already, and because it didn't really get a very good the software support. The most popular one right now is the FitnessGram, and it's really very nice one. It's criterion based, and really the kids whether they're in the healthy fitness zone or not. So classify people and rather than compare it's like you compare absolute standard with the relative standard. Now, just this article give you some background, the history of the FitnessGram. So when we do the health-related fitness evaluation, we have to use different evaluation framework, and that is called criteria reference. And basically, the criteria reference is you have set a kind of absolute cutoff scores. Basically, people say master, no master, fit, not fit, and skilled, not skilled, and just based on the things you're interested in. So the first thing is you need to have this criterion. And to us, if fitness will be whether it's fit or not. And then you will classify and set this cutoff score. So the center of this framework, or the challenge in this part of work, is really setting this cutoff scores. And so the way we typically use is we call the health outcome-centered approach. So basically, the first thing is you want to determine some fitness components that is associated with the health. Then you select the criterion major. For example, if you're interested in cardiovascular endurance, we know that it's related to a number of the health problem, and then we select the criterion. That's say the will to max. But will to max can really done individually, cannot do in the school setting. Then we need to find a field test which can predict the will to max, so the criterion major's performance very well. Then we need to determine the relationship between the major, means the major, the health, and the field test, and then the health outcomes. Then we need to set a cutoff scores, and then determine the relationship. And then we need to do the validation and the cross-validation, try to look at whether the cutoff score is accurate or not. So there's a number of ways to do it. And for the dogs, if we have the information about the health risk, about the fitness component we are interested in, for example, body fat, then that will be relatively easier. And you can just find that relationship. And in fact, that some of the index was found that in the high school adolescents, you will be able to see that. So the body composition cutoff scores in the fitness gram, for example, was really based on the kind of concurrent relationship between the health and the cutoff scores. And they really just looking the a number of the health risk measure and then look the highest risk ratio and determine that cutoff scores. But most time when we do with the children, even they are overweight, even they are obese, you may not really see the health related problem yet. You know, so there's another way will be the theoretical driven from the DOTS information. So we have the information related to say the will to max and mortality. And then we'll derive the cutoff score back based on the growth curve. And Curtin did some excellent work guessing the cutoff scores. So here just show that he was asked to in charge of setting cutoff scores for the fitness gram in the 1990s. And so that time he don't really have any concurrent relationship between the children fitness performance, the aerobic performance, and health risk. So he just he looked at literature and found that skill players well-known study, and this is based on the Cooper longitude study data, and find out that even this center was interesting based on the percentile. It's really quartile, and find that the 25 percentile around that area has a significant change in terms of mortality. So the will to max 35 was determined that will be kind of the minimum level for the dogs. So based on that information, he derived the cutoff scores. I just early used the boy data. He derived both boy and girls data, and the cutoff scores and a different age. Then he set up that cutoff scores and also takes a little bit running efficiency and other related information. But at that time, he didn't really do any mathematical modeling and cross-validation, just pure based on the literature review and his experience. And but the setting cutoff scores, by the way, sometimes it's like a little bit of odds. So you need a panel's the experience. But then he did some cross-validation and also set based on the will to max, also set the 1 mile running time. And run some cross-validation and find a very good agreement. So if you add these two together, 85. So typically we say 0.8 or 85% agreement, it means very good. Means here, the person passed the will-to-max cutoff scores, also passed the running time. Failed the will-to-max, also failed the Weimo run time. Now, recently we also redid, this is really just publication, we redid the cutoff scores using more advanced technique and the method, which is really we call the received operational characteristics curve, so RC curve. And basically, if you get the curve like this, means your classification didn't work. But if you get a curve like this, it will be very good. But how we get it there? And basically, it's the same. So we find people who have the information, no disease, and have disease. And then the fit and not fit. Again, we hope that agreement will be very good. The main interest is here. We hope that the fitness test will be able to pick up the person who is, have the health risk. And so sensitivity is the major things. But anytime you do the classification, there will be the error. And so if we just kind of use graphic to illustrate this, one will be we get the person who without disease with disease, okay? And then say we're using the body weight and normal body weight. Somewhere we have a cutoff score. We say say 25% body fat will be the normal weight. Above will be overweight. And then you set up cutoff scores, and then automatically you will see that there are 4 kinds of index. One will be the true positive. So the person has the health problem, but also was overweight. And second situation will be false positive. Person is healthy, but we said overweight, and so it's a false positive. And so the person was not has a problem. We said has a potential high risk. The other case, in the other side, the person who is healthy, and we also said it's normal weight. And so that's good classification. And but also we could have another kind of mistake. It will be, in this case, we call it false negative. Person is overweight, but no, person has the health problem, but then we said their weight is okay. In real life, you may also see this kind of person. Now, then in the really practice we can do is, because we know the true person who has disease or not disease, and then we can just verify the cutoff points for the fitness measure, and just change the cutoff scores each time we do the calculation, and we can plot it, and then we can do the other directions. So with the computer is set up, and you can do very quickly, just a few seconds. Okay. And then based on that part, and we will be able to figure out that where we get the corresponding point when we cut, and where is that the ideal cutoff score. We can best classify the people. So that's kind of the idea. If you get a curve like this, not very good. If you get 45-degree line, that's just you want to cry. And you get this one a little better, then you get a good test. You get a good classification. Okay? And now, interestingly, that when we compare, now we have some information about the children's risk. I think that the U.S. recently we get some large data set and enhance the measure the will to max, kind of still to predict on the treadmill time. And also, they have some health risk measure. We use the metabolic symptoms to as a risk or not a risk. Now, this is the new cutoff score we set up, and now this just like a 2 category now. But one thing is interesting. This is the work done by the Curtin, and 10 years ago, without any kind of this is based on the dots data, de-driving, but. It's very close. I mean, this is just amazing work. And although there's a little variation, there's a age change, but overall, he did excellent work. And so this really support that de-driver cutoff scores using the DOTS information based on the growth curve, and well, if you don't have enough information, that will be helpful. You can work this way. Okay, and now another thing is in the setting cutoff scores is we typically have a number of the tests measure the same thing. Well, when we measure the body composition, we use the body fat, we use the BMI, we use the skin fold, and sometimes we use bioimpedance, and so on. Okay, and when we measure the aerobic, and we use 1 mile run, 20-meter shuttle, and US called pacer, and sometimes we have a walking test. Now, when you have the set of cutoff scores, typically people do is find a sample, run the correlation, bring the kids to the lab and run the VO2 max, run the correlation, set of cutoff scores, then usually you do not get a consistent passing rate. So the kids have much higher passing rate in the 1 mile run than the pacer, for example. And so recently we did some work using the test equating approach to handle this. So here's the illustration. So typically we said anytime you have a test, a field test. Here said the VO2 max, criterion major. And here's a field test. Anytime you have a new test, you bring the people, do it, and derive another regression line and set up cutoff scores. But because the sample variation, because sample size, and also have a lot of limitations, because test the kids the VO2 max in the laboratory is not very easy and take a long time. And so instead of do this way, we did is we asked the kids who run the 1 mile and the pacer. That's easy. Just 2 different days, run different tests, and they can learn very quick. And usually you have like a large sample, say 200. And then we equate use some the statistical model, and to equate the test from, say, the new test, in this case pacer, to the 1 mile run, because 1 mile run we call the primary field test, because 1 mile run has well done, has well supported validity, reliability. And then from there we translate the pacer time to the 1 mile running time, and predict the VO2 max, and then using the cutoff score set. So that's kind of the approach. And run some kind of the simulation. In fact, the pacer has a number of the equations itself. And surprisingly that it is the equating method that works best with the real VO2 max measure. Okay, so prediction-wise, that the equating method is better even than the pacer equation itself. So this really solved the major problem. So we get a really great progress in terms of how to determine the standard for health-related fitness for children. And but at the same time, a lot of work to be done. The first one is the muscular fitness. Well, first of all, that there's still not a very clear relationship between the muscular strength, endurance, with the health outcome. Some people find that low back pain is related to sit-up test. Some people find there's no relationship. So, and we all know the strength is very important, but there's no clearly kind of relationship yet. And also the strength is not like VO2 max or body composition. We don't really have a criterion major. And if you bring people to the Cybex, and usually that it's you against absolute weight, not the relative weight. When we do the body composition, we do the push-ups and we do the running, we use our own body weight as a load. So it's really kind of 2 different things. And so that's really one of the challenges there. And so any grad students here, and this will be perfect area to do some dissertation and or develop your research line. And then the second part is when we deal with the children, and there's a growth factor there. And so there's very limited information about fit child will become fit dots. And we try to derive the information and from dots and set up cutoff scores, but really have very limited longitudinal data to say, well, this cutoff scores will works. Although I think there's early days, really, University of Michigan professor did some study 20 years ago, maybe more than 20 years ago, find out that the top percentile, very obese kids and very lean kids will tend to keep the same category. Other category kids will move different area. And then the last area really need work will be the motivation. So if we set the standard and too high, too low, what's the impact? And when we have the normal reference, a lot of kids will feel like, well, at 85 percentile, I'll never be able to reach it. And at the same time, some kids who are very good in the essays said, oh, wow, this cutoff scores, this level is very low and very easy to do. So it could be combined the normal reference, criteria reference together. And I think we really need to work in this area too. So let's just quick summarize the thing we learned. I think that health clearly is center of the youth fitness assessment problem recently. I think there's a new supplement will come out. You'll see that there's really some exciting work. But at the same time, many issues and how to set cutoff scores for the muscular fitness, and then there are also cross-cultural issues too. Can the standard set up in the United States be used in the different countries? I'm working with the Cooper Institute to try to extend their FitnessGram to the international right now. So there are many other issues. I'm looking forward to interact with the colleagues here and move the field forward. Thank you very much.